I could address this. Genetics refers to the general principle of linking a piece of DNA with what we call a phenotype, which is basically a trait. That trait can be a disease trait or a trait like, color of hair, for example, or the color of your eyes. So genetics basically is a term that defines the science that links changes in the DNA with changes in a certain characteristic. And so in the case of myeloma, we know that all cancers are ultimately traceable to changes in DNA that we call mutations. And there are several kinds of mutations affecting several different genes and pathways that can set up the malignant process, or that is cancer, or cause its progression in several different contexts. So we would expect, and I'll leave it at that, I'm happy to answer. I don't want to obviously take too long explaining how this could potentially work, but basically you can expect that a particular mutation will cause an effect that is not equivalent to a different mutation. And depending on the mutational spectrum that each patient presents with, the type of mutations that they have in their myeloma cells, you can expect that the disease may be more or less aggressive, for example, or respond to different types of treatment. Genomics is a related process. It's a more young term than genetics. So genetics, the term goes back to the 19th century, right? Remember Mendel. And genomics basically refers to our ability to obtain large amounts of data pertaining to individual patients or populations rather than focusing on individual mutations. So basically, we can get a global view of what happens in the DNA of a myeloma tumor, and we can start making associations, how one gene mutation affects another, how these associations change during treatment. So basically, genomics is a young discipline that was born out of technological advances in the last 15 or 20 years. Genetics is more focused, if you want. Genomics is more global. That would be a generic way of, drawing a distinction.
I think maybe the best way to start with that is a sister cancer for myeloma is called lymphoma. And when we talk about patients with lymphoma, the pathologist can look under the microscope and distinguish one of many, many different subtypes. There's over probably 100, at least 20 common ones, up to 100 smaller, less frequent ones. And because they can look under the microscope and use genetic information to distinguish these types of lymphoma, each of these lymphoma patients is getting different treatment because it's a different disease. The problem with myeloma is when we look at myeloma patients under the microscope, it's not enough. You can't tell who's going to have an easy-to-treat myeloma that's going to be in remission for long periods of time and not require many drugs, who's going to go through treatments very quickly with continual relapses. And so to help us with that, we want a crystal ball. So when somebody's newly diagnosed, what do we think is going to happen with this patient? And so in this crystal ball prediction, we use different kinds of staging systems. And so there's, you might have heard the Dury-Salmon, which we used to use, which wasn't very good because it wasn't very reliable. It included things like how many bone lesions somebody has, which one radiologist might say is 3, the next one says 5, and suddenly you've changed the stage. So we moved from that to the international stage, which is based on just 2 labs, beta-2 microglobulin and albumin. That's easy to do. It's globally done. And I think that's an important point to make because you heard about the health outcomes disparity in myeloma in the US. The 3 of us are actually on this global study where if you think there's diversity in the US, look at the world and the access to drugs that patients have across the world, and also whether or not they're getting these genetic testing. So it's interesting in other countries, if you're cost constrained, can you really do all of the fancy tests that we have? And so going back to the staging, while the beta-2 microglobulin and albumin is helpful, it doesn't incorporate this genetic information. So the next iteration of this is called the revised ISS staging, which not only includes those labs, it also includes a blood test called LDH, and it includes FISH testing. And FISH is basically looking for certain mutations that we know about that are high risk. And the ones most important to remember are deletion 17p, translocation 414, translocation 1416, to a lesser extent, translocation 1420, amplification of chromosome 1q or loss of 1p. So it sounds like mumbo jumbo, but basically those things, if you have those, are considered high risk. Now, it's hard to talk about these without sounding too technically complicated, but you can't oversimplify. So for example, 17p is, we now know, very complicated. It's not just whether you have, so let's say you have 100 cells that you tested for deletion 17p. It matters whether there's 5%, 20%, or 60%. And so you can't, that 5% is not really considered high risk. It's that 60%. So that's one thing. And then also we have 2 copies of the chromosome. So if you've just lost one 17p, that's not as bad as having 2 17p. So you can see that even for something that's simple 17p, it's not one size fits all. But the point is, this information will help guide the therapies that a patient may receive. Truth be told, in the initial therapy, often we're treating people relatively because of new drugs and the safety. I think it's important when we talk about high risk and low risk, yes, we want to improve high risk patients, but low risk patients also benefit from therapies, right? It's just that they don't, what we need to do is better for high risk. And so I think a lot of the initial therapies can overlap. Where we start to see some differences is the role for transplant, what kind of maintenance therapy a patient receives, how long maintenance therapy is continued. That's where we really we don't want to stop. In general, high-risk patients, because of the risk of relapse, we tend to do more drugs for maintenance, longer duration of therapy, less discontinuations, more monitoring for relapses, more perhaps radiologic studies. So that's why this matters. And so we're trying to get to the point where myeloma is not treated one size fits all. And maybe I'll pass the baton on, but if somebody wants to, I think the closest we've come to lymphoma, which is not treating all myeloma patients the same, is the 1114 story, if somebody wants to take that.
I will, before getting to that, because it is so important, just kind of take a step back and say, and this question happens all the time, to say, did my mom and dad give me these genetics or these? Because we sit here and we can sort through and dig through all your data to understand what your myeloma is doing, but we need to probably do a really good job of educating you to say, I'm not talking about the genetics that you received from mom and dad, for the most part, let's say. I'm not talking about genetics that you are going to pass down to your children. That is a great fear of what you are confronting when you are here with your myeloma diagnosis. When we are talking about genetics specifically, we are looking under the microscope and see plasma cells. We then send it off to our friendly pathologists who are able to do more specific evaluation to look at the genes solely in the plasma cells, not the rest of you, not your hair and your heart and your lungs and your kidneys or all your organs, just your plasma cells under the microscope. An important thing, I think, to hear and distinguish. So once we've been able to evaluate what your genetic makeup is of your myeloma specifically, that's where we can start evaluating your risk. So I hope that is clear for everyone.
Sarah Cannon, we actually are basically, we're obviously a tertiary center, but we actually work with a lot of community oncologists. They're my partners. And so I actually see a lot of patients concurrently with doctors in the community that only see 2 or 3 myeloma patients. And it is important, I think, as we're talking about genetics, and Ajay brought this up internationally, but I think even nationally, a lot of patients get their bone marrow biopsy, but they don't get all these specialized tests done necessarily. And I think it is important for you to educate yourselves and ask your doctor if all these tests were done. And if not, you do need to unfortunately consider the possibility of maybe getting another bone marrow biopsy, because these are so important. These are things that we may not be using right now, but we may use in the future. And so the story of venetoclax comes up, right? So if you had your diagnosis 10 years ago and you never got FISH sent, you may not realize that you have this translocations of chromosomes 11 and 14. And so about 20% of patients with myeloma have this translocation 1114, which makes them exquisitely sensitive to this drug called venetoclax. And so now we know this. Now there are studies showing that this is a very important treatment for those patients. And so I think it's important for you to know whether you carry that or not. And that will happen, hopefully. We're all hopeful that eventually that's how we're going to be treating myeloma, that we will be treating you very specifically depending on certain mutations or certain characteristics of your disease that may not be evident now, but may become evident in the near future.
So when we send off the myeloma cells over, or your bone marrow biopsy, you get a bone marrow biopsy, you have the pleasure of one. We take out both your liquid and parts of your bone marrow. We can send it off to a pathologist who is able to, of all the bone marrow cells in there, because remember, your bone marrow is your factory that makes your immune system, it makes your blood, it has all the seeds that make your bone marrow for transplants. They are able to pull specifically out the plasma cells. They have these little tags on them that identify themselves and say, yo, hey, I'm the plasma cell. So they can pull them out, and then they can do very specific fish, as Dr. Chari mentioned, in a very simplistic way. Just kind of throwing in there a fishing pole with a specific lure, if you're a fisherman, a specific little magnet that pulls out what we're looking for. The fish is the process of which we can determine what the genetics are. We know that there's a certain panel of genetics that are most important for us to know about. The several that Dr. Chari mentioned, because it allows us to plug that data into a calculator, basically. And with those different factors within the equation, we can put you into a standard or a high-risk group, which can subsequently allow us to help prognosticate, make some treatment decisions in the very beginning part of your myeloma journey, but also anticipate how to make decisions on your treatment down the road as well. FISH, fluorescence in situ hybridization. Say that 3 times fast.
A lot of times, when a patient is diagnosed with myeloma, not every myeloma cell is exactly the same as the cell next to it in terms of genetics, in terms of the mutations. Often we have small groups of cells that share a mutation, whereas another small group of cells may actually participate, if you want, in another mutation. And because mutations determine the characteristics and often the ability of each individual cancer cell to respond to a particular treatment, when we actually treat the patient, we may see that one group of cells may shrink, whereas another group of cells may expand. And so down the line, we will need to become better at tracking these changes for every individual patient and choosing drugs that promise, if you want, to address the specific mutation in each of these cell types. This is early days for this type of approach. The techniques are becoming better and better, but this will be the next wave of creating personalized therapies for our patients.
I would just add, I think 2 things, which is one is, while we're working towards a cure, most patients and we actually have, that's worth pausing about, there's about 10% of patients that currently are being cured. And the challenge is, how do you find those patients, right? Because the remaining 90% aren't. And so if we because cure requires 2 components. One is that you've eradicated the disease, and the second part is you terminate therapy, and nothing should happen. But then how do we pick that right patient to potentially discontinue? I think a lot of work needs to be done going forward on not continuing treatments on everyone forever, but 90% of patients we're not curing. So how do we address that? And part of the challenge is, I think, we can kind of think about the translocations and the non-translocations a little bit separately. Most patients who have translocations at initial diagnosis, you'll detect that the rest of the course. Those other non-translocations, like chromosome 1 aberrancies, deletion P, 17p, those may not be present at initial diagnosis because, again, you have clonal heterogeneity, right? So there's different types of myeloma clones, and those initial clones may not be readily detectable. They may be lying occult. And what's happening, so on the one hand, we say myeloma is not yet curable, so it's more of a chronic disease. But why is this different than diabetes and blood pressure, right? So your primary doctors are starting you on diabetes and hypertension pills, and you stay on those potentially the rest of your life. The difference is in myeloma, these drugs aren't going to work forever. And because what's happening is the clones that were initially present are sensitive and disappear, but you have new clones that pop up that take their place. And so as patients continually relapse, the remissions unfortunately tend to shorten. And that's why we really want to capture the disease up front. That's our best chance of getting long-term disease control. But as patients continually relapse and they're accumulating these additional genetic hits that Greg was asking about, and that's what is the cause of the continual learning how to beat cocktail drug number 1, then cocktail drug number 2. So that's why we really need to really attack early, hard, and to try to keep these remissions going.
Fotis said it really nicely. Not all myeloma cells next to each other are exactly the same. But a nice analogy I think about is antibiotic resistance, right? You know how us doctors are never all that excited about just handing out Z-Paks? One of the concerns is that if we over-treat with one particular medicine, at some point it may stop working. Basically, that myeloma starts to get a little smart. And we've spent so much time treating that one particular bad actor, putting that to sleep, but that one little rogue cell off to the side, which has kind of remained quiet, suddenly sees an opportunity. And that's when that other guy can start growing. And so when we talk about how myeloma changes over time, what we're saying is that some of those myeloma cells that have been kind of off to the side, not misbehaving, suddenly start coming to life. Whereas the ones you focus so aggressively on killing them off, we did a good job, but we haven't focused on all the different cells. And so that's an analogy that helps me kind of wrap my mind around it. The other thing I would say is we talk a lot about all these numbers and 17Ps and 14s and 11s. Just on a very simplistic myeloma basic 101, we're talking about the number of your chromosome. When we say translocation, we mean that 2 different chromosomes have been cut in half and swapped places. So each half has moved to the other side. So that's when we're saying translocation, so you've heard those words. If we talk about gains or deletions, we're talking about how one particular chromosome has been affected. It lost a piece, it gained a piece, it copied itself. So when we're talking about genetics, we're talking about changes to your specific chromosomes, which is the blueprint that makes you, but also what we're talking about, what makes your myeloma.
Well, I'm not sure it's too dissimilar from what we just discussed, but it's the idea that, again, within one disease, when we look under the microscope, all your myeloma cells are there. They all belong to these different families, per se, and they all have different characteristics. And so when we just look grossly at all of them, we can detect, again, perhaps this loss of this one chromosome in a certain number of cells, but clearly not in all of them. And so there will be particular clones that will have different abnormalities, different mutations. They'll be present all at once. And then as we treat, some will be killed, perhaps, some will be suppressed, and others will start to rise and take over. And so it will continue to evolve in a sort of the most simplistic way, but perhaps there's a more scientific way.
The way to understand it is clonal heterogeneity is the branches of a tree. The tree is myeloma. There are different kinds of branches. Some of them are longer, some of them are shorter, some of them are bendy, some of them are straight. All together, they define the tree, or they are an integral part of the tree. And treatment may chop off one branch or another branch, and then a new sprout may come off of the trunk, right? So you prune the tree when you treat myeloma, but in order to cure the disease, you basically have to uproot everything. Treatment often remodels the branches, but we have to be very mindful about the impact of treatment, and we can sometimes see that new sprouts will come off of the trunk, and then we have to go after them. So I found this as a very useful analogy. In fact, I borrowed a slide from his work, and probably that's a good way to understand clonal heterogeneity. In fact, I just thought, in my language, in Greek, clone means a branch. Come to think of it, I never...